Today's speaker is Dr. Kevin Leal. He is a third-year pediatric resident here at Carillion Clinic, one of the current chief residents. He attended medical school at Philadelphia's College of Osteopathic Medicine. He joined the Bioethics Consultant Service there in his third year and received additional training in this subject matter from UVA. He will be leaving, but not heading off too far. He is moving to Richmond to do a pediatric ICU fellowship. His faculty advisor for this presentation is Dr. Mark Swope, who heads up the Division of Medical Ethics for Carillion Clinic. Under Dr. Swope's direction, the department provides education, policies, and training programs for the greater community and medical staff at Carillion Clinic in responding to ethical dilemmas that may arise in patient care. Please join me in welcoming Dr. Kevin Leal and Dr. Swope.
All right. Good morning, everyone. If there are any issues with the audio, you have any questions, feel free to chat them in. And so my grand rounds topic is about pediatric assent, dissent, and the topic of informed consent. And while they sound similar, they're pretty different. And I'll start by talking about what kind of inspired this talk, move on to the objectives, give you guys a good foundation from which to build your own theories and hypotheses from. We'll do a few minutes of a breakout room to discuss one of these topics, and then circle back to talk about the current legal policies and Carillion-based policies that revolve around this topic. And so, who can you treat without their knowledge? And I call it our narrow ethical topic this morning because it sounds like it's relatively small to talk about, but it has a lot of components you need to think about. And so this talk came from this ethical question when I was doing the ethics seminar at UVA. And it came up that the idea that there was an adult who had bipolar and was off their medication. And because of that, they started to have suicidal and homicidal ideations. When asked by the staff if they wanted to take their medicine while in the ER, they said no. The staff talked to a sister and then gave the patient medication hidden in orange juice. In the rest of the patient's stay, they were calm, polite, cooperative. And how ethical was that? Was it a good idea? Was it a bad idea? Was it something you could see yourself doing, not see yourself doing? And so you think that this might not come up too often in pediatrics, but there are a lot of concepts we can apply. And even like last week, I'm currently on a psychiatry rotation, and a mom was asking about medication for her teenage daughter, who had ADHD and depression, but didn't like to take the depression/mood medication. And her question was, is there a medication that we could switch to or something else that could say is for her ADD, but is actually for her mood disorder? And how could she go about that? And so that is always an interesting, challenging topic to navigate. So overall, the objectives for this talk are going to be kind of review the foundations as it applies to this topic and to pediatric boards, to discuss how to approach ethical and legal issues of kind of covert medication administration, give some legal and historic precedent, and then do that small group I was talking about, and then talk about those official policies. And so first up can be the foundation, and these are the kind of things that come up most often on boards that are most tested on. And so you start with kind of the pillars as we all know them, as we've been taught them either in medical school or in other parts of our training. And those are going to be autonomy, which is that respect to a person's freedom to choose kind of what's right for them and what's not. Non-malfeasance, doing no harm. Beneficence, so making choices for the patient with the intent of a positive outcome. And justice, to treat and provide care fairly for all patients, to allocate resources fairly for all patients. And you kind of take those four principles and use them to help guide your decision making. And so how do you use those principles? So when looking at a patient and working through medical decisions using those principles, you can talk about medical indication. So what is the medical problem? What are the goals of your medical treatment? And those would fall under your beneficence and non-malfeasance. And so making choices that are good for the patient and not doing them any harm. Patient preference is going to be that autonomy. Does the patient know what they're doing? Are they mentally capable of understanding? Are there any conflicts of interest, financial limits, resource limits of the hospital, of the patient? and that would be the justice. And then when also thinking about medical questions, what quality of life is there for the patient after you do those treatments or they go through that process? And so what happens with the treatment? What happens without the treatment? Are you biased in making those judgments? Are they biased in their decision making? Are there any coercive factors coming in? And so those would include those other three principles: that beneficence, non-malfeasance, and autonomy. And so for minors, for the pediatric population, which legally is anyone under the age of 18. So you'll understand as we kind of go through the rest of this talk why parents end up the de facto rulemakers in a legal sense, even if you already kind of knew that intuitively or if that's what society has already presented to you. And so you have parental consent being that default for legal and bioethical framework based on their ideas that the parent is an autonomous unit, the family is an autonomous unit, and they have presumed best intent for their children. After parents, if they're not available, you have the surrogates, guardians, and then last resort is going to be that state and government. And really thinking about minors' minors' capability to make decisions on their own really only becomes relevant if those parents do not achieve kind of policy goals based on government policies, institutional policies, and any implicated constitutional rights for the minor, but also in the context of their family. And so breaking it down in how we talk to and get information from and get agreement from, you have assent versus consent. So there's a helpful table on the right, but really you have your assent, which is agreeing with something, to agreeing to participate in an activity, where consent is going to be giving that permission to. So there's a difference between agreeing to do something and having permission to do something. So we get assent for people who are not of legal age, so anyone under the age of 18 for the most part. We get consent from adults and those who have the capacity to give consent. In research, it's a little different, and legally, assent is not legally binding, where consent can be, although it can always be revoked at any time. And so kind of working through assent versus consent, talking and figuring out regardless of each one, you need to figure out the patient's awareness of the condition. If they're going to agree to something, you need to figure out how to manage expectations, what they expect is going to happen, what they worry is going to happen. We need to figure out if they have the decision-making capability to proceed with assent or consent. And then again, talking about kind of those coercive forces which might happen, financial, parental, societal. And so assent meets the following kind of four elements. And so you help them achieve development appropriate awareness of what's going on, and that's going to be in that pediatric world, so different age groups as we understand them developmentally. Explain what's going to happen with all tests and treatments going forward. Make clinical assessments of patients' understanding of the situation, so you can figure out if they know, if you're all both on the same page, and kind of figuring out if they agree to go forward. And so this kind of falls back to that initial inspired idea of the talk. Is it okay to give kids medication without them knowing? Does that change based on what age they are? If a 5-year-old assents to medication or desents to a medication, does that change if they're 5, 10, 15? And while all of this, and this is a really important topic to think about, the attitude as a whole of getting assent from minors is changing, but one of the last times this was studied in 2006, most pediatricians said they would flat out ignore an adolescent's refusal if parents are already in favor and if the prognosis at the end is good. And does that make sense for us, for how we treat and approach these situations? And does that make sense legally in other situations? And we'll get to that as well. The next part is going to be what informed consent is. And while consent is going to be in non-minor population, based on this talk, thinking about how to apply it to minors and how you kind of want it going forward, it's important to kind of know where it comes from. And so informed consent kind of comes from individualism and autonomy. And the name itself derives from this legal case in 1957 where a patient had an aortogram performed and ended up paralyzed from it. And then they sued, saying that they were not informed that that could be a potential complication. the following legal papers kind of framed and gave us that phrase, informed consent. And so informed consent, depending on where you look at and who you're reading, has 2 to 3 duties. And one of them is going to be let people know what's going on, telling the parents and the surrogates what's happening, and then getting legal to proceed with that. And so that's going to be all that paperwork we have everyone sign. And then other places have a third duty in that sense, which say you need to ensure that there's an understanding of your patient, of the surrogates, of the parents before going forward. And so in respect to pediatric patients, it's dependent on a few factors when we try to get that assent and trying to apply the idea of consent to them, which is going to be their own cognitive ability, so where they're at developmentally, the maturity of their judgment, which is relatively challenging to figure out, but everyone kind of falls back on either their own intuition or their own understanding of development or their own framework based on their conversations with the patient. And then the other part you have to think about is that respect owed to a moral agent. So if you see pediatric patients as their own autonomous people, as their own agents, they have their own free will, they make their own decisions, albeit with different cognitive mature abilities, you kind of owe them that respect that they are that individual, that they have that autonomy, even if it's not the same as the person next to them. And so thinking about and trying to apply those developmental ideas, as just kind of talked about, it's going to be the society emotional control, which is thought to develop around puberty. The cognitive control system, which, as we know, adolescents tend to take more risks, and then as their brain further develops, that kind of tapers off a little bit. And so do adolescents have that ability to make appropriate decision? Do they have the maturity of judgment is something to think about. And the kind of the sense of identity. So what I was trying to phrase as having their own moral agency. So when the 5-year-old tends to follow whatever their parents say, but the 12, 14-year-old starts to have their own what we call rebellious ideas. And so studies looking at the ability of adolescents to make these mature healthcare decisions, they all kind of say adolescence is a good time to think about that, but none of them really agree on when they decided adolescence is. And so the studies looking at it basically come to the conclusion that it's anywhere from 11 years old to 16 years old. And that's not the most helpful of ranges when trying to apply these things and figure out how you want to go forward in your own practice and kind of an institutional practice. The next big thing to think about in terms of making these decisions is what is capacity and what is competence. And so capacity is going to be as a clinician, your determination of the mental abilities of the patient. And capacity is not all or nothing. And capacity and competence are not mutually exclusive. So competence is going to be the legal side of it. So the big legal study / text to determine competence is called the MacArthur Treatment Competence Study, which is a giant book published a couple decades ago. But it's the legal determination that addresses society's interest in the ability to restrict decision making. And so are you competent if you can do the following kind of components? Can you communicate choice? Can you understand facts? Can you apply logic to the different options? And can you appreciate what's happening and the consequences of that? And so as you think about it, at what age range do you think someone becomes competent? It doesn't matter what kind of decision they're making, what type of decision. And legally, as we're about to talk about, it does matter. And then if you think about it in like the hospital setting or in other settings, how do you want to decide if someone is competent to make these decisions, and do they meet these kind of 4 different criteria? And like I said, these 2 things are not mutually exclusive. So if you think about the adult population, where it's more often applied, an adult with dementia might not be able to manage their own finances, but they can participate in healthcare decisions, understanding the situation and consequences of each side. And so adult with dementia is very different from pediatric population. And so what decision-making, what competence do you want to apply to that pediatric world? And so this was a quote I found about the kind of the legal component of the law reviews, is that the law treats generalization of minors' incapacity as a legal presumption. The law basically says if you're under 18, you don't have the capacity to do things, with the following exceptions. And so in Virginia explicitly, a minor is deemed an adult. These are the kinds of things we've all talked about before in regard to treating an adolescent, but this is kind of the actual legal statute. So a minor is an adult if they're treating venereal disease or other diseases that the State Board of Health requires to be reported, if they're looking for health services in regards to birth control, pregnancy, or family planning, if they're searching for services in regards to substance use, and if they're searching for treatment in regards to mental illness or emotional disturbance. So this is something we're all familiar with in terms of the adolescent condition, but I wanted to kind of include it in for completeness, and so you guys have an idea on, one, that this is the actual statute, and two, it can be very state dependent. And kind of the next part is going to be, what is emancipation? So emancipation usually happens legally around this age, age 16, and it's when you're legally free from responsibility and control. And it works, when I say it works both ways, it means the parents are no longer financially responsible or in any way responsible for their child, and that adolescent at this point is not responsible in any way for their parent, and then they do and are capable of making their own decisions. So what does it take to become emancipated? And you can certainly see how this applies in our competence framework. And so a child is legally recognized as emancipated if they are financially independent, and if they're independent and from some of these other components. And so if a child tells you they're emancipated and you have no reason not to believe them, you are legally okay to treat them as such without seeing an actual court order. Virginia, however, requires a court order for emancipation, while other states say that if you aren't that independent, you are automatically emancipated. And so if you think about age of emancipation in comparison to how we're treating everything else, what makes an emancipated minor different from a 17-year-old who still lives with their parents and is financially dependent on them in terms of making these kind of medical decisions? The next slide I'll kind of talk about is what's a mature minor, because some states have this concept in their, set in their statutes and in their laws. And mature minor is a doctrine that minors can consent to things, using that CON, consent to things, not just assent to things, if they show they're mature enough to make those decisions. So almost all states agree that the conditions we listed in the adolescent, the SCDs, the mental health, all counts as consent decisions, mature minor decisions. Other states want to focus that if they're what they describe as mature, they can make other medical decisions for themselves. And so the different kind of points here are going to be kind of that medical idea and the legal idea of what a mature minor is. And legally, it's a political theory about individual rights and what age your rights growing up are your parents and what age they become your own autonomous. And then the other point is there can be that medical point is, should you have the decision making capability and competence based on your capacity and social maturity? Those are different and harder to measure, and certainly harder to put in any kind of legal code or make it that simple. So the noted Supreme Court precedent that comes from where mature minor kind of comes from is this case where down in Georgia, it was a class action lawsuit by minors, by patients who were committed to state hospitals, so state mental institutes. And this lawsuit discussed and was for stating that the state was not doing due diligence for the admission of these parents. It was basically saying, oh, parents, you want to drop your kids off at this mental institute. We agree that you think that they have these disorders and need this treatment. We'll take them. And so this lawsuit was basically saying that the minor saying, hey, the hospital shouldn't be dumped on ground. You can't just agree to whatever the parents say. And that matters here because we think about that mature minor part again. So if you have that 16-year-old parent say, hey, they need to go to a mental institute, and the kid says, hey, no, I don't. Who's right? Who's right there, and where does the law fall down? And this is kind of that court precedent that kind of falls on that. And so one of the quotes from this would be, the law's concept of the family rests on the presumption that parents possess what a child lacks. So in maturity, experience, capacity, judgment required for making life's difficult decisions. And then historically, it's recognized that the natural bonds of affection lead parents to act in the kind of the best interest of their children. They decided that exceptions to this, which while anyone who's worked in pediatrics know exist, are rare enough that they don't need to do anything else legally. And so the other part of the mature minor point is that there's no consensus on what maturity means, especially legally. And so in Virginia, there are a couple more exceptions, which we should talk about real quick, which will be adolescents can consent if they're emancipated, which we talked about, and to be emancipated, financially self-supporting, a court-ordered emancipation. In Virginia, all emancipations have to have that court order. Or if you're married, you are legally married, you can consent and you're emancipated. It doesn't have to be currently married, it could be a past marriage. So if you somehow have a 16-year-old who is married and divorced, they can still be emancipated. Pregnant people can consent to the care of their own child, but cannot consent to their own care up to that age of majority unless you have those prior adolescent conditions. Any active duty people are considered emancipated, and anyone in inpatient psych treatment, legal exception is going to be that the minor has to participate in the decision-making process, but they don't necessarily have to agree as much as the parent does, but there must be participation. And then there's the other part, legal exceptions, where you can be treated without that parental consent is going to be those emergencies, if the child's in custody of the state, if there's written authorization for another adult to have custody, and then if only one parent of some autonomy to make some decisions, and how would you restrict some of them, I guess? Not all of them. Dr. O'Neill is going to leave it at 18 because children are variable and you might as well stick with what's currently working or not working, depending on how you view it. And then Dr. Permeshwar wants to have graduated consent, and she would institute a system to allow certain decisions to be implemented at different age ranges. And all of those are very valid and certainly good ways to look at it. And so I can go to the next slide. So based on the kind of the scenarios presented, here's some of the things you might have talked about. MacArthur, too many outside factors determine maturity or ability to make decisions at a specific age can't determine this. Yes, that is very true to an extent, but historically we kind of agree that 18 is that change, for better or worse. And while there are a lot of different factors that go into it, at some point there has to be a line, right? These are some of the decisions you might have talked about, especially in the transplant patient scenario. So you can't force families to undergo certain things, certain medical procedures. In this case, it was an Amish family who had sought alternative treatment. And so different barriers for them to get that transplant, which might not be feasible for them, would be the frequent medical visits, the different costs of medication, the lifestyle, and then are the alternatives reasonable? Is one choice better or worse than the other? And who gets to make that decision of what's better or worse? If there's social concern, so unable to get to the hospital for a transplant, if one becomes available for them based on where they live and their lifestyle. Then also thinking about if a parent declines a procedure for their child, where is that coming from? And do you have to think about child abuse? Is there a reason for neglect? Or there's other burdens kind of influencing that decision? And so these are just, like someone in the chat said, there are so many factors that go into all of these decisions that while there exists that hard and fast age 18, we all know that there's so much variability and all of these different factors can influence these decisions. It's certainly challenging. And so how did the concepts for which we applied so far, I know what you guys might have used but not known the names for, would be kind of these standards for surrogate decision makers. And this will be quick because this could easily be its own grand rounds. And each one of these has its idea that's good and parts of it that are bad. And so the most common thing we use is the best interest standard. Is this in the best interest of the patient? So is it the option that maximizes the person's overall good health and minimizes their risk of harm? So the big issue with the best interest standard, and AEP published an opinion piece about this a little bit ago, is that oftentimes there's no such thing. Best interest is very subjective. It's often very vague, misleading, and kind of egocentric. So when pediatricians determine that the course the patient chooses is not reasonable, the decision should rest with parents who clearly care for their child. Is that the best interest? And then the points that I was talking about in terms of egocentricity and those kind of issues, you can apply to like vaccinations. So is it in the best interest of a patient to get vaccinated if there are side effects? So if there are known adverse reactions, even if it's like 0.1% to that individual, probably, maybe not, but to as long as the rest of the population is vaccinated. So if you have a community of 100 people, 99 of them are vaccinated, should you vaccinate that last person? Is it in the best interest of that one person, or is it in the best interest of the community? And so you can kind of see how the best interest standard has its own issues. The next thing you guys might have thought about would be that harm principle. So people should be able to act to autonomy, however they wish, unless their actions harm someone else. And a good way, quote that kind of encapsulates the harm principle is, your freedom to swing your fist ends where my nose begins. So this is a principle that's designed to restrict, not kind of encourage or embrace decision making. It's most commonly applied to like criminal activity and thought sometimes applied to personal liberty. In the adult world, like smoking and drinking, you can do that as you wish until it affects someone else. Secondhand smoke, drunk driving, etc. The next kind of principle you might have thought about would be that parental autonomy. So anything goes as long as the child's basic needs are met. And parents have that presumptive right to not interference from the government, from the state. And it's a right that is only restricted or could only be restricted if they fail to provide for their child's basic needs, as based on the legal understanding of what those basic needs are. The next standard you might have thought about would be kind of that shared family-centered decision-making. And do you have everyone in agreement, something that's not always feasible? There's often a lot of times and chances for coercion with those. And it can sometimes set unrealistic expectations. If the patient is like, I'm going to be all better and walk out of here, and then you look at them, it's like, nah, your leg's coming off. That kind of discordance isn't easy to make that family shared decision making. And then finally, the other kind of standard you might have thought about would be substituted judgment. And so in the sense that patients can't make decisions for themselves, which is more of an adult concept for those who become incapacitated. And we have here at Carillion something called a special friend. And those special friends are people who have known the patient for a long time and try to make decisions in that patient's best interest. And so you can easily apply that to the pediatric world. However, there are a lot of issues with that in the sense that wants and desires can change over time, and current situations can change people's idea of what they would want going forward. And then past decisions don't necessarily influence their current decisions. And so a study was done on this one, showed that surrogates were only about 68% accurate in figuring out their loved one's best decision or what they would want. And so that's obviously not a great percentage, but better than nothing. And the other issue with substitute judgment is that going forward, if you want to decide about treatment on something as an adult, you don't necessarily go, it's not yes or no. You talk to your doctor, you get information from other people. And so people often want other people's input on final decision making. And so substituted judgment has its own issues as well. And so those are kind of the standards, the names for the standards you might have used when kind of figuring out your decision on changing the age of maturity and kind of those concepts. And so what are I don't know how animated that slide, but I kind of like it. So the specifics in terms of current policy and precedent. And so what's at stake here in this sense? So pediatricians are often permitted and sometimes obligated to treat children of their objections, but doing so always creates a residual moral harm. And so if someone is screaming at you not to do it and you say, I'm not going to do it, but they do it anyway, that especially creates moral harm, which can have long-lasting effects in terms of their mental health and well-being. And so that's something that needs to be acknowledged. And going forward, And so I'll talk about that in the sense of the current AA couple slides. And so legally, in 1987, this case stated that you need a sense of identity and stable, deep-seated values to make autonomous decisions. And so the courts kind of decided this rule of sevens, which said there's no capacity for anyone under 7. Everyone over between 7 and 14 lack capacity unless they can prove otherwise. In that sense, their opinion can matter a little bit more to your final decision. And capacity is then presumed, but can go the other way. And you can say everyone has capacity, but that might not matter because we can go the other way at 14 and older. Remembering capacity is not competence. And so in 1995, the AAP published this article on ethics, which talked about only obtaining consent if you're going to listen to it. And William Bartholomew, he was a pediatric ethicist at the time. He published this opinion piece, which was very animated and definitely set the tone going forward. And his arguments against the AAP's policy at the time would be the initial policy said you can exclude children. Children can be excluded unless there's a perversive reason. And that concept is very vague. And so his idea was that you should always include children in decision healthcare making to whatever extent they're capable of. Because the concept would be, what is perversive reason to exclude them? So is it too stressful to talk about cancer diagnosis? Is it too frightening to talk about upcoming surgery? If you're going to have that vague ability to take away their ability to assent, then that's too subjective. And in that sense, you should include them in those decision makings. You shouldn't have that exception. The next thing was that the initial policy talked about impasses regarding the interest of minors. So our parents and doctors and the healthcare system disagree on the next steps forward. And they said that it was a rare occurrence. And his argument was that, as anyone who practiced medicine knows, it's anything but rare. And then finally, if you won't abide by their dissent, don't ask for permission. So don't say, hey, if it's all right with you, we're going to give you this vaccine. And then they say no. That just completely mocks the idea of that of assent and has that moral injury. So you're ignoring them, you're acting against them despite their own expressed desire for autonomy. And so acknowledging that can go a long way, even if you still have to go forward with it. And so I included a citation if you want to read that. It's pretty good. In 2016, the AAP came out with another policy to kind of talk about the informed consent again. And so they amended their earlier statements from 1995 a bit based on a lot of what was published. And so while many children lack the agency required to be autonomous agents, we're obliged to act out of fundamental respect for other people by virtue of their personal autonomy. And so not ignoring their assent and dissent in this case. And so the next thing that they talked about was acting in the best interest of the patient and using informed permission. And then finally, the idea that autonomy is within a family unit, not necessarily an individual in terms of final decision making. And legally, that came up in a case of Meyer versus Nebraska, which established a kind of eventual decision that parents have a right to establish home and bring up children without influence by the state and government. And so some of the things and ideas that we want to do would count as that influence. The next thing is going to be that kind of that Carillion policy, which in terms of here at Carillion, our pediatric policy states that parents are regarded as the best able to appreciate their interests of their children. So the things we talked about before, in the sense that parents often have the presumed best interest of their children at heart, regardless of the issues that we already talked about, what that might mean. And then the other thing that our policy states is that if continued treatment is no longer in the best interest of the child, and you have the ability to redirect other interventions. Carillion has a policy for what happens when patients, parents, and the healthcare system don't agree. And it's a drawn out committee with a bunch of different people, ethicists, vice presidents, etc., with a 2-week period to kind of come to a resolution before going forward. And so that's available on inside Carillion if anyone has an interest in what it might mean. The other part that the Carillion Pediatric Policy says is that we're applying the best interest standard to favoring interventions that are likely to provide greater benefit than burden. So something that we talked about in our small interest group was likelihood of success and what that burden going forward might be on the patient and on the family. And then Carillion Policy also says discouraging the initiation or continuation of interventions that are likely to change that ratio, so to increase that burden over benefit. So what do you do if parents refuse, and when can they refuse? So parents can refuse consent for minors, just like they can consent, they can dissent. And if the doctor disagrees with that dissent or their refusal to consent, you can override it. And so they can have different reasons to refuse to consent, but the reason that you can choose to override it was going to be in emergencies. And so you can treat over parental objection, keeping in mind anytime you do so might end up later in court. If the parent then sues, you might have to defend those actions in a sense. And so talking to your department ethicists and lawyers and going forward with that later on. And then the other time that if parents refuse is other court orders. And so when there are court orders, I'll show the actual form in a little bit, but the things that the court thinks about in their own legal setting is going to be the age, that risk versus benefit, and then the likelihood of what happens if you do nothing, and then the likelihood of success. And they reportedly take all of those factors into their consideration for overriding parental refusal. Keeping in mind that most of these things are going to be a little subjective. Things like age and certain named risks and benefits are objective. Other parts are subjective, and so different courts can decide different things. And so here's an interesting case that happened in Virginia explicitly, which led to a law called Abraham's Law. And so this patient, age 16, named Starchild Abraham Cherix, which I put the full name because it's an awesome name, developed Hodgkin's disease and declined treatment. Treatment resulting from his condition at the time had a 95% 5-year survival rate. Patient declined treatment because the side effects of the treatment while it was going on made him wish he was dead. Parents agreed with their child and were then sued by the government for neglect. And so thinking about which way this case might go based on the things we talked about, but it resulted in this law called Abraham's Law, which says that parents can choose these alternative treatments for their adolescents, age 14 to 17, with life-threatening medical conditions, taking into effect the mature minor idea. So if the teenager seems to be mature and everyone's talked about and considered all the treatment options, and then they all agree in what's the best choice for the patient, then parents can choose and agree with those alternative treatments and decline treatment in this case. And it resulted in this law. And in the sense that Starchild Abraham was able to decline treatment, was then legalized. And so this is eventually overriding the refusal. While we talked a little bit about what a court order is an ongoing process of research, and then focusing more on like the legal framework. You have to think about who can do that overriding, and really it's only the government. So if you think about those emergency cases where you override parental decisions, when you override parental decisions and come back to it, and then you might have to defend yourself in court later, that idea is still the law coming up with the final decision in this sense. And so while you might think your component matters a bit more, it ends up in the state. And then the next part is going to be that general consensus of harm and overriding that refusal, considering refusal rate, and the likelihood of success. And so thinking about that harm and your success of treatment, does a 60% chance of success change your thought, is it different from 70%? Do you have a treatment threshold for what you would consider benefit versus harm in terms of going forward? Dr. Keyes, the last thing I don't actually know beyond 2017 where he was last known to be alive for Abraham Star trial. And so, thank you, Dr. O'Neill. And then, so overriding that refusal has this kind of framework. And so this, as I promised, is the form for what you need, what ends up getting filled out for non-emergencies if you need to fill out form and try to override parental refusal. It's available on the state website. So just to kind of review our objectives, the things we talked about already is going to be, we review kind of the foundation of ethics as applied to this topic in the pediatric boards. We discussed how to approach ethical and legal issues. We talked about legal and historical precedent. We had that small group time, and then we explored official policies regarding these issues. And so we'll do some maintenance and certification questions, and then have a couple minutes to talk about conversation at the end. And like I told Dr. Parmeshwar at the start, there are actually a number of ethics, Calvin and Hobbes comics, which have application here. And so the first question is going to be a 7-year-old girl, and these are pulled straight from prep. And like I promised, can focus on the kind of foundation here on this first one. So a 7-year-old girl admitted to the ICU with a liver laceration grade 3. Parents refused to consent for blood product transfusion because they are Jehovah's Witnesses. You start setting up for the transfusion anyway, explaining that the patient may die without it. And so what ethical principle gives you that ability to set up for that transfusion despite parental objection? All right. So ethical principle that applies best in this case can be that beneficence. And so you have that obligation to act in the best interest of the patient, which can sometimes override autonomy. Patient autonomy in this case, per PrEP, does not apply to young children. So this patient is 7, so patient autonomy does not apply. And patient autonomy is that informed patients can make their own decision. Justice is going to be that fairness in distribution, and it's not like you're taking blood away from someone else to give it to this patient. It's something that factors into your decision making. Substituted judgment. Minors have a surrogate decision maker, so you don't have to substitute your judgment in this case, and so that doesn't apply. And the capacity is the ability to understand, which we talked about, which does not apply to your ability to set up for blood transfusion. And so the second question is going to be also from PrEP. And so this is a multi-institutional study wants to examine the impact of web-based interventions for weight loss in obese adolescents. It's required online participation, monthly body measurements, and blood tests every 6 months. So once a 17-year-old meets all eligibility criteria and they're approached for participation in the study. And so what consent versus assent things require for study enrollment? So the answer here is going to be D. You need informed consent from the parents and assent from the adolescent. And so I put in the percent correct, just so you guys know how everyone else has done those prep questions. And so talking about, so informed consent, you need that disclosure of information, you need assessment of understanding, and then you need overall agreement between the parties and documentation. So kind of that legally binding consent part. Minors having limited autonomy does not apply legally here for study enrollment. And in this study, so it's not one of those legal exceptions that we talked about. And then you need that assent because from explanation and agreement to participation in the pediatric population. All right, these are my references. I bolded informed consent and decision-making pediatric practice, something published by the AAP in 2016. Which is a very good and helpful review. And then that's it. Does anyone have questions or thoughts or comments they would like to add in at this time?